Hi everyone, my name is Yazan Douedari and I'm honored to be presenting my research at the second Syria Health Conference. Let me share my screen. So I'm going to be presenting today research with the title A Qualitative Examination of Health System Governance and Adaptation under Three Areas of Military Control in Syria. This research has been done by the Syria Research Group, which is co-hosted by the London School of Hygiene and Tropical Medicine and National University of Singapore School of Public Health. Um, so when we say health system governance, what do we exactly mean? It's usually defined as the actions and means adopted by a society to organize itself in the promotion and protection of the health of its population. And it's important because the research has shown that supporting health system governance during conflict could have an impact on the post-conflict rebuilding of the health system. Now, moving to Syria, Syria is currently divided into approximately three major military controlled areas. Each area has its own general governance structure, and specifically, it has its own health system governance structures. These areas are the opposition controlled areas in the northwest, the autonomous administration controlled area in the northeast of Syria, and the government controlled areas in the rest of Syria, which is in the center and the south of Syria. Our research objectives were to explore health system governance and adaptation across Syria during the conflict and to identify potential and feasible health system strengthening interventions. The methods we have used were qualitative methods. So we conducted 52 semi-structured key informant interviews in late 2012. These interviews were in all three areas of military control in Syria, and it was also across all governorates of Syria. So we try to be inclusive in terms of including all 15 governorates of Syria, and we oversampled women with over 55% of participants being women. This is because of um, the underrepresentation of women generally in health research and specifically in Syria related research. Our participants were divided into three categories: public health providers, private health providers, and service users. The interviews were done remotely using internet call application like WhatsApp and Skype. And we are actually in the process of developing a paper explaining the methods, a separate paper explaining the methods we have used. And the analysis was a thematic analysis relying on transcripts that are in Arabic that has been analyzed by bilingual um, researchers. And we used the Siddiqui et al. Framework that has 10 governance elements, and we explored all of them, but we will highlight only a few of them today due to time limitation, starting with accountability. In accountability, we noticed that although there was a complaint system for service users across all three areas, we noticed that service users preferred to avoid the system that existed and to just have a direct complaint outside of the system. So they would go, for example, to the health facility manager or someone from the admin team and talk to them orally rather than having it written and channeled through the system. And this could be linked to to the reported lack of trust that service user has, and this has probably dated to before the conflict. And we this is a code that described the situation in a nice way. After the crisis, we started to have complaint culture, but at the same time, people are afraid to complain. Most doctors have power. And we noticed or it was reported that the private sector has no complaint mechanism and it has not been receiving any complaints. And also, it was highlighted a strong role of the social media. So service users will be using the social media as a means to hold health facilities and health providers accountable. Now, in terms of the rule of law, um, the laws in health facilities are reported to be enacted by the supporting NGO and they are not fixed. So they would change by the change of the supporting NGO or by the change of um, for example, the health facility manager. And even when these laws uh, were there, they were not fully implemented. And this is another quote from one of the public health providers saying, if there were two secondary healthcare centers 2 kilometers away from each other, each center will have its own policies according to which NGO is supporting it. And it was perceived that the private sector laws were not written. So it was perceived that the private sector has laws. These laws are not written, but they exist in the minds of these private health facility managers, whether it's a clinic, small clinic, or a bigger facility. Now, in transparency, we it it was noted that there was a disagreement between providers and service users when we asked them about the availability of health information. And by health information, we mean here like what services exist, how to access these services, prices. And as you can imagine, providers were reporting um, that the information is generally available, while service users are reporting that it's not that much available. In terms of how service users accessed these information, the word of mouth came as the most means that was used. After that, the social media was reported as a way to access information. And lastly, people would go to health facilities either, sorry, either to ask directly um, or to see it written somewhere in the health facilities. It was perceived also that there was a lack of recruitment and financial transparency generally and in all areas of Syria. And this is a nice quote of one of the public providers summarizing it. Um, I might read in the news about seizing the funds of the hospital I work in, but I would not know this from the hospital management team. No recruitment process was reported in the private sector. Now, in terms of equity, when providers and service users were asked about the presence of discrimination within the health sectors, there was a disagreement there, with the majority of providers saying that there's no discrimination, and most service users were reporting some sort of discrimination. This discrimination was mostly as favoring the locals over internally displaced people, or favoring the rich over the poor, or those with power, relative, friends, and acquaintances. However, almost all participants reported that discrimination, when exist, it was not systematic. It was not within the system. It was just individual acts. And this is a nice quote that I would like to highlight. This is a public health provider saying, we as health professionals can discriminate between patients, but we might favor our relatives. But generally, there is no discrimination. So you can see from this code that favoring relatives is not really perceived as discrimination by providers or by most providers that we interviewed. And also, it was reported the presence of discrimination across areas of military control, and this is mainly reported by participants living in areas outside the government-controlled areas. and they reported that they fear detention and prosecution if they wanted to seek help in government-controlled areas, just because they live on the other side. Now, in terms of participation, service users reported that they are generally consulted when it comes to their treatment plan. However, this participation was mostly an approval of or rejection of the treatment. And it was also reported that the decision in terms of the treatment plan, it was sometimes given to the family rather than to the individual. Now, this is a cultural practice that is common in Syria and has been common even before the conflict. In terms of participating in in decision making, this appeared to be very weak in all areas of Syria, but specifically weak in government-controlled areas. And when it did exist, it was through surveys or representative. And this is a code that I would like to highlight. I asked one of the participants when he was talking about participation. I asked him, so how do people participate exactly? He said they submit complaints. So as you can see, this is not really participating people in decision making, and this reflects the lack of understanding of participation by many providers, unfortunately. Now, the strategic vision, it was not always present, but when it did, it was focused on increasing coverage of services, medications, and health professionals. However, most service users reported that they do not really know the vision of their local health authority. And it's summarized here by a nice quote by one of our participants saying, having a strategy is difficult for us. It is more of a vision and periodic plans, subject to each period situation. Our vision, which is our dream, is to have enough coverage in Syria so people don't have to travel to outside Syria to receive health services like Turkey, or to travel to regime-controlled areas which might pose a risk for their lives. Now, we have three conclusions of this research. The first is support for health system governance in one or more governance area could start by strengthening accountability and participation at facility level among Syrian and international actors. Second, any external support should be led by local health actors, as these remain the most legitimate health system governance actors in all areas. Third, supporting efforts should start now to nurture ongoing governance initiatives that could then have opportunities to develop and mature once the conflict has ended. And I would like to end by a quote of one of our private healthcare providers saying, it should start from now. Healthcare does not wait. There are victims of low quality health services. Thank you very much.
Hello everyone, this is Ibrahim Masri from University of Calgary, Canada. First, I have nothing to disclose, but I should acknowledge that this research is funded by the Canadian Institute of Health Research and the Faculty of Graduate Studies, University of Calgary, and Refugee Health YYC Research Program. So, as you know, diabetes prevalence is projected to continuously increase globally, with more pronounced increases among low and middle income countries such as Syria. Syria remains the number one source of refugees globally, with more than 6.6 million uh, refugees, the majority of them sought refuge in Lebanese countries such as Lebanon. Lebanon hosts the largest influx of refugees per capita, including an estimated 1.5 million Syrian refugees. The vast majority of them live in urban areas, with around 17% of them are living in camps, and more than 73% of them live below poverty levels, and the majority of them lack residency permits. A recent survey in Lebanon reported high proportion of households having at least one adult with NCD among Lebanese Lebanese and Syrians. And there is an urgent need for novel solution to alleviate the burden of diabetes among refugees. And the need to evaluate diabetes care models in protected refugee setting was recently highlighted in the Boston Declaration 2019, where several organizations, including WHO, UN agencies, MSF, and other institutions set for major targets to work towards over the next 3 years, including unified and strength advocacy, universal access to insulin and other essential medication and technologies, establishment of unified set of clinical and operational guidelines for diabetes and humanitarian crisis, and improved data and surveillance. So such a program was the Diabetes Care Program for Refugees in Lebanon, DCP. DCP is a refugee-led program that leverages existing local healthcare infrastructure to provide free consultations, medications, and lab tests for diabetic refugees. So DCP structure and care processes were innovative and inclusive, and this may represent an effective care model for refugees, but hasn't been formally evaluated. So our objectives are to characterize the DCP structure and care processes using the WHO framework and calculate DCP program costs across all implementation phases. So the WHO framework called 6 Building Blocks of Health System Framework, and which is a universal tool to assess health system performance, and it was used by the Lancet Commission on Diabetes to assess challenges associated with providing diabetes care in a humanitarian crisis. So the 6 building blocks include governance, financing, health workforce, medical products and technologies, and information, in addition to service delivery. So our methods, this is an embedded case study as part of an ongoing quantitative study, including secondary analysis of retrospective cohort data to characterize the DCP structure and processes in Lebanon and determine its care outcomes and associated costs. The unit of analysis was DCP program, and subunits were 4 mobile health teams, settings, 8 locations in Lebanon, and time between September 2016 and March 2019 across phases. Data sources were program documents, including care protocols, monthly reports, training materials, and financial statements. And we also analyzed DCP costs in US dollar, including salaries, medication, investigation, and admin costs. So here are our results. DCP served 4,000 diabetes refugees between September 2016 and March 2019. There were 4 phases. The first one was only a rapid assessment between February 2015 and August 2015 across 5 clinics. And then 3 actual phases of the program. The first phase was between September 2016 and March 2017 across 8 clinics. And then phase 2 between April 2017 and October 2018 across 7 clinics. And the final phase was across 7 clinics. And those clinics were in 5 regions in Lebanon. So here are the structure of the DCP: first, leadership and governance. DCP had 1 medical coordinator and 1 leading organization called Multi-Aid Programs, MAPS, and 1 DCP committee, including MAPS, Syrian American Medical Society, SAMS, and International Diabetes Federation, IDF, 2 human resources. They were all refugees, but during the pre-launch phase or rapid assessment, they were volunteers, including 5 physicians and 1 data entry. And then across the 3 phases, or the actual 3 phases of the program, they were employees, including 4 internists, 4 nurses, 1 full-time data entry, and 1 part-time accountant. 3 medical products and technologies. DCP leveraged existing clinics, and they used the same list of medication and lab tests in all clinics and all locally sourced. So, for example, Medication during the actual 3 phases of the program include 5 types of insulin, 3 oral anti-hyperglycemic agents, 1 statin, and 2 ACE inhibitor. For technologies, during the first actual phase of the program, they used point of care HbA1c, and then they used A1C or standard A1C from labs. For information, so during the rapid assessment, they used hard copy survey and Excel database, and then during the 3 actual phases of the program, they had a unique ID card for patients, and they used paper medical records and central Excel database, and then during the last phase of the program, they launched pilot EMR. Financing, as you know, many transactions were slow and restricted. DCP have accounting system, but they don't have local bank accounts. So they used cash. Many donors involved in this program. So during the pre-launch and phase 1 of the program, Qatar Red Crescent supported DCP, and then SAMS supported the 3 actual phases of the program. And finally, World Diabetes Federation supported the last phase of the program. Expenses were vary across phases. So for example, phase 2 accounted for 58% of the expenses. So for processes, we will focus only on the service delivery. So during the pre-launch, patients were assessed clinically only for 1 time and received medication for 3 months. And then during the actual phases of the program, they had intake, which include clinical and lab assessment in addition to medication prescription, education, and then follow-ups every 3 months, A1C every 3 months, and annual ophthalmology consultations. And then they changed during the last phase to A1C every six months and ophthalmology consultation as needed because of the lack of funding. Healthcare workers received training from IDF, Anti-Diabetes Diabetes Association, based on WHO and IDF guidelines. Workshops were conducted every 6 months, in addition to ongoing online technical support by WhatsApp and email. So here are the costs of the program. Over 2 years and a half, the total program cost was $550,000, and the average cost per patient per year was $208. So the proportion of the costs include 26% for medication, 25% for investigation, 40% for salaries, 5% for logistics, and 4% for initial cost. So to summarize, managing diabetes during humanitarian crisis presents challenges, and managing diabetes among Syrian refugees in Lebanon is challenging. DCP partnered with international donors, leveraged existing local healthcare infrastructure, and displaced Syrian refugee providers to care for diabetic refugees at relatively low total costs. This may represent an effective NCD care model in conflict setting. And our limitation, this is just a descriptive case study with preliminary finding, but it's part of an ongoing secondary analysis of retrospective cohort data. And our cost analysis is just including total program cost, not cost effectiveness analysis. And our patients were only diabetic Syrian refugees in Lebanon. However, the core structure and processes of the DCP could be generalized to other humanitarian settings. So this study presents an opportunity to evaluate diabetes care model in conflict setting, and our finding can inform healthcare system responding to chronic disease such as diabetes in a humanitarian crisis and aligned with the Boston Declaration for Diabetes. So for the future, we will continue in our study to evaluate DCP outcomes and investigate how program structure and processes relate to clinical outcomes, and also will conduct qualitative study among DCP providers and leaders. So thank you for having me, and would like to acknowledge my team, our donors and supporters, Feel free to send any question.
Good morning, my name is Kristen Meagher and I am privileged to be here today to speak on such an important subject, particularly against a backdrop of global momentum on women's rights and equality. This presentation is an exploratory review of the role of women's leadership and health systems strengthening in northern Syria. It aims to put forward some questions and ideas that require further research. This research is also a substantial part of a new 4-year research program on health system strengthening in northern Syria, funded by the UK's National Institute for Health Research. The presentation today will discuss research more broadly that I have been undertaking on women's leadership in health and conflict settings, the existing literature and what health system strengthening tells us about gender and active conflict. Then I will look at the specific case study that is northern Syria and how women are contributing to healthcare there. I'll also touch on some of the barriers and opportunities more broadly, and I will end with some thoughts on how to continue the momentum for this research agenda moving forward. This research is nestled within the Women Leaders in Health and Conflict initiative, which sits across both the Research for Health and Conflict program and our new program on health system strengthening in northern Syria. The Women Leaders initiative was established to highlight and support the work of women leaders and the groups that they represent in conflict settings. This research is also part of the broader political agenda towards gender equality. This includes the United Nations Security Council Resolution 1325 on women, peace and security, which was established in 2000. There's also the Sustainable Development Goals, and specifically number 5 on achieving gender equality and empowering women and girls. This is also part of World Humanitarian Day, which in 2019 honoured the role of women humanitarian workers. In general, research focuses on health outcomes for women, and very little is known about how women are contributing to the health and conflict-affected settings. Even less is known about what women's leadership might mean in such contexts. It is well known that health is an area delivered by women and led by men, and that women from low-income and middle-income countries comprise just 5% of leadership positions in global health organisations. In conflict settings, however, there is no substantive data available on the number of women in health leadership positions. We do, however, know that women are at the forefront of improving health for conflict-affected populations, be that through service delivery, education and capacity strengthening, advocacy and research. For example, it is estimated that over 40% of the 500,000 humanitarian workers who provide frontline care during emergencies, wars and disasters are women. In a global context, women account for 70% of the health and social care workforce. Despite progress and calls for change, women remain largely segregated into lower status and lower paid jobs in health. They're subject to discrimination and in some contexts are under the constant threat of violence. Additionally, women do not form a homogeneous group. Therefore, when women are excluded in decision-making and policy implementation, other groups are also disadvantaged. Disadvantage is multiplied by the intersection of gender with race, ethnicity, caste, or religion, for example. Conflict-affected countries present unique risks and challenges to women who work in healthcare. We know that women are disproportionately affected by conflict and humanitarian emergencies, and that conflict itself promotes conditions during which existing gender inequalities and inequities are amplified. Furthermore, the health and conflict settings also uniquely positions itself in non-permissive and often highly securitized and politicized contexts in which attitudes and assumptions towards leadership are predominantly male-normed. The growing evidence base demonstrating excess female morbidity and mortality reflects the necessity of evaluating the role of women in leadership, driving health research, policy and programmatic interventions in conflict settings. So what does the research tell us about health system strengthening, gender and active conflict? Generally speaking, the existing literature on health system strengthening mostly overlooks not only women and gender more widely, but also armed conflict. Most of the research focuses overwhelmingly on the post-conflict phase, and while of significance in an era of protracted armed conflicts, the role and contribution of women, particularly as leaders within these contexts, has become increasingly important to understand and to furthermore support the divergent needs of conflict-affected populations. Health systems are gendered, and health policies work to reinforce women's gendered roles and responsibilities. Gender also influences how people interact dynamically in complex and context-specific ways, reflecting varying interests, values, and power. And therefore, gender is at the core of health and health systems research. Some research has found that health system literature in general is characterized by the belief that gender is part of the broader social determinants of health, therefore important in shaping health outcomes, but external to the health system itself. When it comes to leadership more specifically, we know that inequality in leadership inhibits productivity and performance within health systems and has individual and national health and socioeconomic impacts. Promoting women in senior levels in the health sector could have important impacts throughout the health system. Evidence furthermore indicates that when management does not include sufficient women or gender-sensitive tools, women's health needs will not be reflected in local health priorities, and financial and human resources will not be allocated accordingly. Building on the current literature and my current research, the Syrian conflict, specifically the Northwest and the Northeast, provides a vital context in which to study this complex relationship, that is, the intersection of health systems, gender dynamics, and active conflict. The Northwest and Northeast have employed different mechanisms and strategies to support their health systems, and the role of women within these differs. The Northwest has witnessed devastating violence, which has caused a serious disruption of health services and ongoing attacks on healthcare facilities and personnel. Despite all of these challenges, local health and medical networks in this region have developed a hybrid health system. The Northeast also faces ongoing disruptions to health services and has developed its own unique health system, which is also supported by various NGOs in the region providing healthcare. These two regions are furthermore controlled by different political factions, and these groups have varying respective policies on women's rights and representation. Despite the immense efforts of women since the uprising, across Syria more generally, women's participation in public, social, and political life is very limited and remains a contentious issue. Discriminatory social norms relegating women into private and domestic spheres remains a key challenge. Women's participation in regime institutions, for example, has been deemed tokenistic and uninfluential. In the autonomous administration and the Syrian Democratic Forces, that is in the Northeast, women hold senior leadership roles across policy functions and at all levels of their institutions. However, female leaders have to balance new policies with the views of conservative locals. In the Northwest, the Syrian opposition lacks female leadership. In opposition-held regions, no pretense of formal legal equality or legal protections is made. Tahrir al-Sham, which controls much of Idlib, for example, excludes women from political bodies and limits their basic freedoms. How then are women contributing to health in northern Syria? Last week, the Women Leaders in Health and Conflict Initiative held a webinar to discuss the role of women's leadership in Syria and its importance in supporting the health needs of conflict-affected populations. Throughout the Syrian armed conflict, women have participated in and contributed to the health system. Women make up a large proportion of frontline healthcare staff. Healthcare personnel face considerable risks here due to the conflict. It is very difficult to obtain accurate quantitative and qualitative data on how many female healthcare workers are impacted and what their specific needs are. So while the role of women has altered during the Syrian conflict and has meant they are becoming increasingly influential in the public sphere and in shaping Syria's future, within the health systems themselves, we see that there is a lack of female representation in influential leadership roles. This is hindered by the various fragmented health systems themselves, the political situation, a lack of support from colleagues, and restrictive provincial rules to female leadership. In the Northwest, for example, a female candidate applied for a role on the Health Board of Directors. The candidate was unsuccessful on the basis of not fulfilling the criteria, a criterion created to purposely exclude women. Where gender issues intersect with other disadvantaged groups, for example, individuals restricted by poverty or living in rural areas with low opportunities to access education, then women who are aspiring leaders in the health sector are further marginalised. The COVID crisis, too, has also reinforced these barriers and the gender gap. The COVID task force in northwest Syria, for example, is underrepresented by women, with just 1 woman and some 30 men. So to summarise, there are a number of barriers: entrenched socio-cultural gender discrimination, which results in an immense pool of untapped talent, ongoing patriarchal attitudes, the women's burden of unpaid work, a lack of experience and opportunities to participate in leadership, ongoing security issues. However, amongst this, there is also a wealth of opportunities. Field research shows that conflict and humanitarian crises create potential spaces to challenge the barriers. So women's rights advocacy and localised responses can facilitate shifts in power and resources and transform gender relations. It's also important to create strong networks, and enhanced collaboration between researchers and practitioners will strengthen networks and increase the much needed evidence base. The voices of women in health and conflict must be made visible through social media platforms and advocacy groups. We also need open and honest discussions which can aid in shifting mindsets by challenging gender norms, unconscious bias, and reframing our perceptions of leaders. The role of the diaspora groups and international institutions and other advocacy groups is also vital in engaging with women who are aspiring leaders in health. They can provide mentorship, role modelling, support access to opportunities, and training programs that develop female leaders. As the research suggests, attaining leadership positions is a serious challenge for women contributing to the health sector, and this is perhaps more pronounced in active conflict. So a vital yet challenging next step is conducting both quantitative and qualitative research with feminist methodology to determine the leadership needs and health system strengthening in northern Syria. Through this, my objectives are to identify and analyse these challenges, explore how gender norms and culture influence health systems, and develop a framework for health system strengthening in active conflict that incorporates gender analysis. This acknowledgement of women's contributions and vital role in health systems through meaningful leadership may provide a blueprint for advancing gender equity and equality across conflict-affected societies and supporting wider peace-building initiatives. Thank you very much.